Hey, good morning, everyone, and welcome to UroNurse. We meet every Saturday at 9 a.m. Central Time. And if you're joining us on Zoom, on YouTube, great. Be sure to hit that like button and that subscribe button. If this is your first time joining us, be sure to check out our website at uronurse.com, where you can learn more about us and how you can become part of the program. It's also the best place to go to see all of our past episodes. We've got them all available on demand. All 29 episodes. This is our 30th episode today. Woohoo! So it's really been a great journey, a great ride. I'd like to thank a new sponsor that's joining us as sponsoring the program, and that's the Poesis Medical Company. They were our speakers last week with the duet catheter. It was really interesting. And if you're interested in sponsoring the show, because that's, of course, how we are able to afford to keep this going, hit that sponsor info button on the website and find out more about how you can become a sponsor. Again, as usual, if you're joining us on the live audience and you want to ask a question, just use that Q&A button. Hit that. Go ahead, ask any questions you have. We'll take some general questions. We got a great group of panelists here that'll be more than glad to answer any general questions. And then we're going to get into our program this week. We have Dr. Berger joining us. He's going to be talking about testosterone therapy. This was one of the subjects that we had a lot of demand for from the audience who has the ability on the surveys to say what they want us to talk about. So we're looking forward to that. And at this point, I think I would like to go ahead and bring our great group of panelists on for an introduction here. So for those of you that are maybe new to the program, my name is Vic Sinise. I'm the producer and host of the show. I've had 30 some years of urology experience, and this is my way of paying it back to everyone. And Aaron, why don't you go ahead and introduce yourself to everyone?
Hi, Aaron Berger. Had the pleasure of working with Vic for many years in our practice in Chicago. I'm the Chief Medical Officer at Associated Urological Specialists in the southwest suburbs of Chicago, and happy to be with you and talk a little bit about testosterone therapy.
Great. Andrea.
Good morning. My name's Andrea Strong. I'm a urology nurse practitioner in Wisconsin. I've been working in urology in some form since 2010. I've worked inpatient, outpatient, telephone triage procedures, everything in between. I'm certified as a urology nurse, and I'm excited to be here with you all this morning.
Always great to have you. And Lori.
Good morning, everyone. My name is Lori Atkinson. I've been in urology for 24 years now. I am a certified urology registered nurse, currently working at Delnor in Geneva, and we just opened an office at Central DuPage Hospital in Winfield.
Great. And last but not least, John, go ahead and introduce yourself.
I'm a private practice urologist in Gilbert, Arizona, who wants to pay it forward by sharing my experience in the business of medicine to benefit my colleagues. I have a strong interest in coding, billing, compliance, efficient practice management, marketing, social media, and online reputation management. I am actually streaming this, Vic, to the Thriving Urology Practice Facebook group, where over 2,100 US-based urology practice personnel join to collaborate so we can lift all ships.
Hey, it's great to always have more promotion. John's been really good at helping to promote the program, and we've got a lot of growth in the program. So our next thing, I don't see any questions coming in here. Well, let me just double check. Yeah, nothing coming in on the Q&A. So we're going to go into our favorite stories. I didn't have a long chance to talk to anybody about a favorite story if they have one, but if you don't, that's great. If you do, that's great too. I have a favorite story though. I'm going to kick off with, and that's UroNurse. So it's a crazy idea that I came up with, and the group in Chicago Metro helped to form this and make it happen. But I have to tell you that it's been amazing at how well it's grown and how fast it's grown. So one of the things that I look at is Google search. So Google search actually this week sent me an award for the most searches that my programs received. So that was kind of a neat thing to get. Also, it gets broadcast on YouTube live at the same time, and it has the video on demand through YouTube. And we are now getting over 100 views for each new episode as it airs every week. So that was kind of an amazing statistic. Our subscriber base grows every week. We're up to 70 subscribers as as of the last time I looked. So I'd like to thank everybody that comes to the show live, and those of you that are coming to the show and watching it on demand, because we're, of course, going and covering the entire United States. We have viewers from all over the country, and one coming from Sydney, Australia. So we are international at this point. And I just want to say thanks. That was my favorite story for this week. Anybody else have a favorite story? I'll be glad to turn it over.
I have a story that happened this week.
I was
It's
hoping,
always-
Lori, that you'd have one. Yours are the best.
I have one every week, and it's not even old. It's always new. So we had a patient that came in for a vasectomy. He did well after the vasectomy. He chose not to have the MA in the room while he dressed. All of a sudden, I'm getting called, Lori, we need you here. He is on the floor, like on the floor, half in the bathroom, half in the procedure room. Like, we don't know what happened. It ended up being that he obviously got the tunnel vision and everything, but the problem is that we didn't witness it. So we don't know whether he hit his head. We don't know whether he, got hurt. Luckily, we're in the hospital at Del Norte. So I did suggest going to the ER because we did not know what happened to him. And so he went to we brought him down to the ER. He was alert and oriented, and his blood pressure was okay and everything. But he's like, my head does hurt a little bit. And I'm like, all right, yeah, we need to bring you. So we brought him, and he's fine. But the learning from that is just make sure you're in the room with patients, especially after procedures. You never know what's going to happen.
Yeah, that's a good point, because I get involved in prostate biopsies, and it's always the burly truck driver guy who's, yeah, I'm fine, no problem, who sits up and goes, whoa. So always keep an eye on him for a while just to be sure. All righty. Anybody else with a favorite story?
It's either those guys or the guys that have tattoos everywhere, and then they go crazy when you give them a little Novocaine.
It's always that. It's funny, the guy who comes in and says, I'm scared, I'm really worried, I think I'm going to pass out. They never pass out.
Well, this guy that decided he didn't want the MA in the room, now he's got 4 girls around him and he's in his underwear. So
Oh, Lori, that reminded me of a story that happened once. So I was doing some training in my nurse practitioner residency, and I was in the room with the urologist. He was performing an exam on a male patient. And a young guy, he's just standing there. And all of a sudden he tilts his head and rests it sort of against my shoulder because I was standing right there. He actually just passed out and then kind of rested his shoulder on me. So, yep, it does happen.
Yep. Well, that's great.
So the classic signs,
right?
Signs of passing out, the sweating, they start going like this. They start getting fidgety. Those are the classic signs that they're going to pass out.
I'll add one more sign that I've learned. I have to go to the bathroom. When somebody suddenly urgently wants to go to the bathroom, I go, no, absolutely not. Now you're going Trendelenburg till I'm sure you're, and then of course the color changes and everything else. But that bathroom one, that's a sure sign.
Well, having done thousands and thousands of vasectomies, did about 2,200 vasectomies in the last 2 years. Before I started using laughing gas or nitrous oxide, I had a few patients who would vasovagal, who would pass out. And another one of those signs was, boy, I'm feeling really, really thirsty. But since using laughing gas, I can count on maybe one finger the number of patients who try to pass out. It works really, really well.
Yeah, I love the anti-anxiety effect of the nitrous. I agree. It's made a big difference. All right. Well, now we're going to go switch over to our full show, and I'm going to ask Aaron to switch to the screen share. And while you're doing that, I'm going to go ahead and announce all the wonderful attendees that I see up on the screen. Somebody's actually calling in by phone. That's interesting. But I see April, and oops, I can't see the screen anymore. So I'll quit announcing names, and I'm going to go turn it over to Dr. Berger.
Sorry, Vic. I didn't mean to
Oh,
lose your
that's
screen
okay.
share there. All right. So welcome, everyone. Thanks for the invitation, Vic. So we're going to go through a little overview of diagnosis and treatment of testosterone deficiency. Again, I'm Aaron Berger. I'm from southwest suburbs of Chicago, formerly, well, still working with Vic, although Vic's doing more of his influencer presence these days online versus working in the office. But he taught me many things when I was very green 15 years ago. So well, we'll get right into it. So certainly any questions, use the Q&A, and we have plenty of time for some questions at the end. So okay, so what is the definition of testosterone deficiency? And this is kind of a rundown or summary of the guidelines from the American Urologic Association. They're a bit dated from 2018, but I don't think there's been a tremendous amount that's changed in the world of testosterone in the last few years. So typically this is defined as 2 morning testosterone and or free testosterone levels that are below normal, and the traditional cutoff for low total testosterone is less than 300. But some labs do have different reference ranges, and the testing should be done in the morning. So testosterone levels do decrease somewhat throughout the day, and this is a good excuse for insurance companies to deny coverage. So if you have a testosterone that's done after 12 p.m., they'll say, oh, it was done in the afternoon. It doesn't count, and you have to redo it. So I'm sure if Dr. Lin is a expert on coding, he knows all these tricks the insurance does to try to avoid payment. And some of the reference ranges for different labs, they just use different cutoffs as far as standard deviations from the means. So really, this less than 300 range for your total testosterone is really what we should be looking for. And if the patient is symptomatic, so if you see a patient, someone's checked their testosterone, it's a little below normal, and they have no symptoms, they don't really need any evaluation or treatment. So it really requires symptoms and the lab levels to be low. So causes, so you can have just age-related testicular failure or testicular decline. Other common causes can be chronic pain medication or narcotic use, can depress testosterone production. Patients have had prior chemotherapy, if they're on chronic steroids for other medical issues, if there's any history of pituitary dysfunction, and a history of HIV or AIDS, but certainly with all the medications available for that, we don't see too many cases of this anymore with full-blown HIV symptoms, but just to keep in the back of your mind. But these are some of the common potential causes of low testosterone. So initial laboratory testing, beside just the testosterone and or free testosterone, so LH or luteinizing hormone is the hormone that basically stimulates the testicles to make testosterone. So certainly this is something that you may want to check as well to really figure out what the cause of their low testosterone is. So if they have low LH and low testosterone, this is considered hypogonadotropic or central hypogonadism, where they're just not getting enough production of LH from the pituitary. If there's high LH and low T levels, this is more of a primary testicular issue. Now, as far as the actual cause, some insurance companies, if you're trying to get patients on therapy, will require that they have a diagnosis of hypogonadotropic hypogonadism, and you really have to check the LH levels. And oftentimes this goes, with FSH kind of comes together, LH, FSH, sometimes prolactin levels as well. It's kind of a panel we often will run for infertility, but the key thing here is the LH. But it really depends on the provider and the insurance if you really need the LH, because ultimately the treatment is going to be similar. Prolactin levels, you can check if the testosterone is normal. If the testosterone is low and you have a low to low normal LH, just to make sure there's not a potential pituitary issue. Estradiol levels, if patients have a low T level and gynecomastia as a main complaint. Baseline CBC to check the hemoglobin and hematocrit levels, so you can compare to the levels once they're on treatment, and we'll discuss why this is important a little bit later. And certainly PSA levels should be checked in men who are above 40, or if they have risk of family history or other high risk factors for prostate cancer. So what are some of the symptoms of testosterone deficiency? There can be some cognitive symptoms. A lot of men just have some depression or lethargic. They can have some cognitive dysfunction, concentration issues. Sorry for the typo there. Concentration memory issues, sometimes irritability or mood swings, reduced motivation to really be real active and do a lot of stuff. Certainly sexual side effects is one of the main reasons that patients will come into the office to be evaluated if they have reduced libido. They also can have some erectile dysfunction. The data is still a little unclear if the low testosterone is really affecting this at all. It seems the main issue as far as erectile dysfunction with low testosterone is really just that reduced libido. As I tell patients, if their head's not in the game, they're going to have issues with their sexual performance, since such a significant part of sexual function is upstairs above the shoulders. So that certainly can be an issue. As far as physical symptoms, low energy, fatigue, decrease in muscle mass and lean body mass, weight gain, loss of body hair. People used to have a nice full lush beard. Sometimes that is not working anymore. And then diminished physical performance. People say, I go to the gym, I work out every day, I'm just not seeing any results. All those things can be symptoms of testosterone deficiency. So here's just a little graphical interpretation of this. So the low testosterone is, mental fogginess, fatigue, tiredness, some depression, some of that adipose fat deposits in the midsection, low sex drive, erectile dysfunction, and also risk of osteoporosis. So with low testosterone, you can have an increased risk of bone loss, similar to men who are on therapy for prostate cancer with medications to induce low testosterone. We always want to discuss bone health, so this can be a factor for men with low testosterone as well. So the optimal testosterone helps the bones, helps energy, can increase muscle mass and lean body mass, and clearer thinking as far as their memory and concentration and focus. So as far as counseling patients, so this is some of the highlights from the AUA guidelines. So testosterone deficiency can increase the risk of cardiovascular disease. There is good data to support that. Testosterone therapy may help improve libido, sexual function, lean body mass, and bone density. It is currently inconclusive, at least as of the guidelines from, like I said, 2018, if testosterone therapy improves energy, cognitive function, or lipid profiles. So there is some, been some back and forth and controversies over the years about whether testosterone is really helpful for kind of metabolic syndrome as far as lipids and sugar and all those kind of metabolic factors, and as well as cardiac disease. There was a time where they thought it really potentially worsened the risk for cardiac disease, but that data is really not, that doesn't really support that conclusion. So they're basically saying here that it's inconclusive to counsel patients, but certainly the majority of patients I see do feel better on therapy. And you do want to assess desire for future fertility. We talked about earlier the LH and FSH pathway. So if you do give them exogenous testosterone, and we'll discuss the treatment options in a few minutes, this basically will provide negative feedback and will actually decrease the FSH production as well, which will decrease their sperm count. So if patients are interested in having children in the future, that may affect the choice of what therapy you're going to give them, or they may just opt to not go on any therapy at all. There's no definitive evidence that testosterone therapy increases rates of thromboembolic events. There's no evidence that testosterone therapy will cause prostate cancer. This is kind of another urban myth that's on online that people will say. It's like, oh, if I take this, I'm going to get prostate cancer. The way I typically explain it to patients is certainly testosterone is involved with prostate cancer. So if they have undiagnosed prostate cancer, certainly that can accelerate things. But as far as causing it in the first place, there's really no evidence to support that. And again, as I mentioned on the last slide, there's no clear evidence at this time if testosterone therapy will actually affect the risk of cardiovascular events. but there's certainly no evidence that it in general increases the risk. So whether it decreases the risk, that's for future studies. A lot of people believe that, but right now they're just saying no clear evidence one way or the other. So testosterone in the circulation. So there are several proteins that testosterone can be bound to. So about half of the testosterone is bound to albumin, and this is a loose binding with the testosterone. About 2% of the testosterone is free, just in the circulation, not bound to anything. 44% is bound to something called sex hormone binding globulin, and this is a tight bound. So this is really not available for the body to use. And then 4% is bound to something called corticotropin binding globulin. This is, again, a loose association. So there's something called bioavailable testosterone, which is basically a combination of the free along with that bound to albumin and the corticotropin binding globulin, which are the loose associations. So this the amount that's bound to sex hormone binding globulin is not really available. So some patients just seem to have a higher amount of this sex hormone binding globulin. So even if their total testosterone levels are normal, their free testosterone or the bioavailable testosterone may be low. So it's important if you have a patient who is symptomatic, they come in, they say, oh, I have bad memory, I have weight gain, I have no energy, I'm decreased libido, all those classic symptoms, and their total testosterone looks okay. It's really important to check that free and or bioavailable testosterone to see what they really have in the body that can be used. As we discussed earlier, there's a wide range of variability in terms of reference ranges. You can send something to one lab and it'll be less than 300 is below normal. I have some labs here in Chicago that they'll go down as low as like 240 or 220 even for the total testosterone. And this is all just different definitions of normal based on the number of standard deviations from the mean as far as what the lab is setting. But if a patient is symptomatic and does have a low absolute level, the recommendation from the AUA is that you still should consider treatment. Now, are you going to be able to get that treatment covered? If they have a level that's quote unquote normal on whatever lab they're using, that's a different story. But if they're less than 300 as an absolute number and symptomatic, you still should consider treatment, at least according to the guidelines. So let's move into some treatment options. So one of the first kind of treatments for at-home use was the testosterone gel. There were, several brand names when this was available as a branded medication. There was, Androgel. There's one called Axiron for a while that went under the armpit, almost like a deodorant. There was Testim, which was the little tubes for single use. So really now all of those are generic. So the most common is just the testosterone gel, which does come in, different strengths. It's typically 1% or 1.62%. We do have some patients who get the pump, which is the most common. Some insurances still use the single-use daily tubes. So typically this gets applied to the upper arm, shoulder area daily. I typically recommend, having patients do this, after they shower and are getting dressed, because you don't want to get this wet for at least 2 to 3 hours after application. There is the risk of transference. So women and children really should not be, coming in contact with testosterone gel. So for people who have children or grandchildren who are on therapy, if the patients are on therapy and they have children or grandchildren, coming by and they have short sleeve shirts on and they, the kids are jumping on them and playing with grandpa or dad. You don't want to have the kids be in contact with the testosterone gel. So they got to be cautious of that. These are generic at this point, as I mentioned. So often this is the initial therapy that we can get insurance coverage for. There is a percentage of patients, roughly about 15-20%, they just don't absorb this well. And it's unclear exactly why this is. As I tell some patients, they could take a bath in the stuff, it just doesn't work. So some patients who do 2 pumps, 3 pumps, whatever, their levels just don't budge. So it's unclear exactly why that is, but for some people it just doesn't work. And in some patients, they do get some skin irritation. It's not real common, but it certainly can happen. Everyone, there's people have sensitive skin, so that can happen as well. There is also a testosterone patch. I think that used to be called Androderm. But that's generic as well now. So there's 2 milligram or 4 milligram patches. So you do 1 to 2 patches nightly, lasts for 24 hours. So it's between 2 to 6 milligrams is the dose you want. So you do, a combination of 1, 2, and 1, 4, or 2, 2s, really depending on dose titration. Again, these, can work pretty well, assuming patients can absorb testosterone through the skin. But again, some skin irritation can occur, and this is more common as far as skin issues with the patch than it is with the gel. Clomiphene. So clomiphene is a medication that's been around for a long time. It's classically used for infertility for women to stimulate ovulation. But since the pituitary pathways for men and women, as far as LH and FSH, are similar, it is also used to help promote the production of more LH, which then stimulates the testicles to produce testosterone. So basically, clomiphene blocks the estrogen receptor at the pituitary, and estrogen basically is acting as the off switch, in essence, for this hormonal pathway. So some testosterone does get converted to estrogen naturally. So when the pituitary sees estrogen, it basically will decrease the production of LH and FSH for men. So by blocking this with the clomiphene, it keeps the LH and FSH production going, which will then subsequently go to the testicles and increase testosterone production. So this can be taken either 25 milligrams daily or 50 milligrams every other day, which is what I typically use. And if patients do have an interest in future fertility, this is really the go-to medication, in my opinion, because it does not suppress and, in fact, enhances their sperm production. So they may have, even better chances of more children than they do without the medication. So it kind of has a double benefit if patients are having some issues. A lot of infertility patients, when they're going through that, stress of that whole process, sometimes the interest in sexual activity or the libido is decreased, and sometimes they do have a low testosterone or low normal testosterone. So this does have somewhat of a double benefit. And it is generic, so it is relatively easy to get and get covered for patients. There's also 2 other oral medications, which are actually synthetic testosterone. So these are not stimulating. Pretty much everything else we're talking about here is not stimulating natural production, but this is this is actual testosterone therapy. So Jatenzo has been out for a few years. It comes in 3 different strengths, all nice round numbers, 158, 198, and 237. So not sure exactly. It's I'm sure the studies just found those were the right doses, but a little confusing there. But so you can always reference your pharmacy book. But the starting dose is typically 237 milligrams twice a day, and then once you get patients started on therapy, you can either go up or down depending on how their labs work and how they are feeling. Another newer medication came out a couple years ago called Tilando. This comes in 112.5 milligram pills. And again, starting dose here is 225 milligrams BID. So you're taking 4 pills a day. So it is a decent number of pills. Both of these, in my experience, do work well. But, they do have some difficulty as far as insurance coverage. So, especially because these are oral medications, these come out of patients' pharmacy benefits, not as much as their medical benefits. Which is 2 very different things. So the cost of these sometimes can be prohibitive for some patients, but if they are able to get them, they do seem to work pretty well. Testapel. So Testapel's been around for, it's probably 15, 16, 17 years at this point. So basically, this is small pellets that are about 75 milligrams each. These are implanted subcutaneously every 3 months. Typically in the buttock is the typical place that these are placed. So the starting dose is typically 6 pellets, but then you can titrate up if levels are not therapeutic and or if their symptoms are not improved. So basically, the patients come in, you prep a little area in the kind of the upper outer quadrant of their buttock. You make a small stab incision, and then there's a needle and a little trocar needle that goes in. You slide that in, and then you remove the inner part, the stylet that has the sharp point on it, and then it's basically a hollow introducer that you slide the pellets in. It's kind of like loading a shotgun. You kind of slide the pellets in and then you use the little pusher device to push them in. And if you're using more than 6, then you can either do 2 rows, so kind of in a V pattern. So I typically will kind of do like one go in this direction, one go in that direction, or some variation. And there's also a technique where you can stack them. So you kind of do 3 deep or 6, 6 deeper, and then a few more closer to the surface. And then basically you just do a little steri-strip and a little tegaderm, and that's it. And they do that every 3 months. I mean, the whole procedure takes a minute or 2, and patients tolerate this pretty well. And it is kind of out of sight, out of mind. We put them in and they're good for 3 months, and they don't really have to think about it. And there's no risk of transference, since there's no way anyone can, touch under the skin in their buttocks. So that's not gonna be a concern. Another option is something called Aved. So Aved is a depot or long-lasting intramuscular injection. It only comes in 1 dose, and it's done intramuscularly in the office. And patients need to be watched in the office for 30 minutes. So when they did the clinical trials, there were the emulsion liquid that this is in, it has some fatty droplets. So there were a couple patients that had some shortness of breath, and they found they had these small, basically like little fat emboli that can go to the lung. No one died from this. This isn't like a pulmonary embolism where people drop dead. They just had a little shortness of breath, and they were fine. But based on those couple situations, the FDA does have a warning that you basically have to observe these patients and document you observe them, and that they had no respiratory issues for about 30 minutes after the injection. So these days, when everyone's got their phone, they can sit there and watch Netflix or whatever. It's not that big a deal. Or watch past episodes of UroNurse, would be even better. Then they have something to do, so it's really not that big a deal. Most people don't really have a problem with this. The schedule with Aved is you do an initial injection. The second injection is about 4 weeks later, and then subsequent injections are every 10 weeks. And the recommendation from the company that makes this is that you don't check their repeat labs until after that 3rd injection. There's kind of a ramp up period to kind of get the levels to steady state. So if you check their testosterone after the 1st or even the 2nd injection, you may not see that they're having the full effect. So you also want to counsel patients not to be discouraged if they don't feel, fully improved until after that 3rd injection. And then there's this generic IM injections, which people can get through specialty pharmacies, compounding pharmacies, or a lot of even just local drugstores, Walgreens, CVS, whatever, will carry testosterone cypionate, which is the most common form used. So this is something a lot of times patients will just be instructed to do at home. They can inject themselves in the buttock and the thigh and the hip. And this is typically done either 50 to 100 milligrams, either sub-Q or IM weekly, or some patients that don't want to do the injections as often, do 100 to 200 milligrams every other week. It's relatively inexpensive as it is generic. But since you're doing these frequent injections, the testosterone levels do tend to kind of yo-yo a little bit, or if you track their testosterone, does have a little bit of a sawtooth kind of appearance sometimes, where they'll kind of go up and they're good for several days, and then it kind of starts coming down, especially if they're doing it every 2 weeks. But it is a relatively inexpensive option. It's pretty readily available, and a lot of patients do fine with this. And again, there's no concern for transference because it is going either under the skin or in the muscle. Along the same lines is another medication called Xiasted. So Xiasted is a weekly auto-injector. So I liken it to an EpiPen that people use for allergies. So basically it comes in 50, 75, or 100 milligram dosages. So that should say 50 milligrams, not 50 grams. That would be a little much. Patient never really sees the needle. So patients who just can't do an injection themselves because they have a needle phobia. I'm sure there's a better name for needle phobia than needle phobia, but that's a lot of patients just don't like needles, or can't inject themselves, or don't have anyone at home that can inject for them. So the nice thing with this is they never really see the needle. So they basically take the little cap off the device. They squeeze a little area of belly fat, hold it against the skin, and basically press the button. And after about 10 seconds, they hear a click, and it's there, and that's done. So this is subcutaneous weekly. Again, this is a very good option if you can get insurance to cover it. but a lot of guys really like this, that in my experience. But again, it does take a little more work as far as getting coverage. So those are the main options. I think I neglected to mention there's a nasal gel called, I think that's still around, called Natesto. I don't know, I haven't heard a lot about that recently. It was a nasal gel testosterone that gets absorbed through the nares. But I've not seen that one recently. So, but it's another option, again, that is for patients who fail topical gel that doesn't go through the skin. So as far as follow-up on treatment, so once patients start on treatment, you should repeat their labs after about 8 to 12 weeks of starting therapy. And that doesn't always mean 8 to 12 weeks from when you see them and give them the prescriptions, because a lot of these products, as I mentioned, insurance does put a lot of restrictions on testosterone, especially brand name testosterone products. So sometimes it can take a few weeks to even get the medication, as far as prior authorizations and getting it from the pharmacy and all that kind of stuff. So you really should do 8 to 12 weeks after they've started treatment, not just from their visit. So sometimes it's good to have the patients let you know when they're actually starting. And I typically will do a total testosterone and a free testosterone, because as I mentioned, sometimes the testosterone can be bound to other proteins. So you want to make sure that the free or bioavailable is actually improved. You also want to check their CBC. You want to check a PSA. And then if they are stable on treatment, they're happy with their treatment, they feel better, they are having a better sexual function, better cognitive function, better physical improvements, then typically repeat the labs every 6 to 12 months. And the recommendation from the AUA is that if their levels improve, but there's no symptomatic improvement within 3 to 6 months, you really should discuss discontinuation. So, if their levels look great, they have normal testosterone, normal bioavailable or free testosterone, they don't feel any better, then, why are we doing this? And you really should discuss potentially stopping the treatment and then having them look for other causes, whether it's more of a mental health issue or, being screened for other issues, thyroid function, things of that nature. Because if they're not better, then there's really no point in, just treating lab values. You got to, make sure the patients are symptomatically improved, as that was part of the definition, that they do have symptoms. So if the symptoms are not better, then it may not be best in their best interest to keep doing the medication. So one of the potential side effects that needs to be discussed is something called polycythemia, also called erythrocytosis. And this can occur with testosterone replacement therapy. You need to check their CBC on a regular basis. So if the hematocrit or hemoglobin, mainly the hematocrits, what I worry about is too high, which, typically they would define in most labs as above, 54%, most labs. That can cause some hyperviscosity of the blood, where the blood is actually getting kind of too thick, and that can lead to headaches, fatigue, blurred vision, and paresthesias in some cases. So if you have patients that really are happy on their therapy, they feel much better, their sexual function's better, their mental function's better, they're happy about their life overall, and they don't want to stop the medication just because their hematocrit's too high, you can have them see a hematologist. And a lot of times I work with several hematologists, and they just get them set up to do routine phlebotomy, where they'll go in and they'll just, basically, remove some blood, and that will reduce their hematocrit levels to a more appropriate level. And, it does sound a little crazy sometimes that people go in and get bled basically like a vampire, on a regular basis. But if they feel better with the therapy, this is a good option if they do have that side effect of polycythemia or erythrocytosis. So some patients, especially if they are obese and have more fat cells, can develop elevated levels of estradiol or female hormones when on therapy. And this sometimes can blunt the effectiveness of the testosterone. I guess one of my stories I could share, Vic, is I had a patient who is on therapy. His testosterone was doing really good. He was up like 600-700. Felt better, sexual function was better, but he told me he was watching some like Hallmark Hall of Fame movies with his wife, and he was in tears, which he said he never happened to him before. So I said, let's check your estradiol levels. And he was, up like 60 or 70 on his estradiol, which certainly is higher than it should be for men. So, so fat cells do have an enzyme that converts testosterone to estrogen. So not that this can't happen with, men who are pretty fit or thin, but if they do have a bit of a belly with some extra fat cells, they definitely have a higher risk of this conversion. So there is a medication called anastrozole, or Arimidex is the brand name. This is 1 milligram weekly that basically inhibits the aromatase enzyme. So it will decrease the production of estradiol. So their testosterone stays more as testosterone. So with that, I think that's all I have for slides. So happy to take some questions. So I'll stop sharing here and let you take over here, Vic. And if anyone has any
Sounds
questions.
good. All right. Hey, that was great. Really comprehensive. You covered most everything. So I'm sure there's a few questions out there. Again, audience, go ahead and put those in on the Q&A. I had a couple of questions. Have you heard anything about the use of all this plastics? You know, everybody's drinking their water out of a plastic bottle, and there's some claims that the estrogens are leaching out of the plastic and increasing some of this, you know, estrogens in our male population, decreasing their testosterone. Any thoughts on that?
Yeah, I mean, I guess, you know, the studies and data, you know, there's a lot of stuff about, I mean, not only that, but just, you know, the effect of all these microplastics or nanoplastics, and for a lot of health issues. So that's certainly one of them. I mean, I don't know if there's anything specifically we can do to test that, or, you know, or find out if that's really the cause. But either way, at this point, yeah, exactly. There, what is that? Your plastic free,
Yeah,
BPA
metal.
free.
I use all metal cups now.
Yes.
I have for a long time.
Yeah, I mean, I'm sure there's a lot of environmental factors and things we're all exposing ourselves to just in daily life that can lead to some hormonal imbalances, you know, not just for men, but for women and anybody else. But, you know, as far as, you know, treatment and evaluation goes, you know, regardless of cause, you know, those will be similar, and we'll tell everyone to start getting reusable metal cups.
There you go. It's the answer. I got to invest in Yeti stock.
There you go.
Paula Wagner said, or asked this question: I follow the endocrine guidelines. They are comprehensive. Do you do replacement after treatment of prostate cancer?
Yes. So I didn't discuss that. So basically, that also was one of the guidelines. I neglected to put that in as a bullet point, but yeah, there's no contraindication to doing testosterone therapy if patients have been treated for prostate cancer and they basically appear to have been cured. So if patients have had prostatectomy and their PSA is undetectable, they've had radiation therapy or other therapies and their PSA is low and stable, there's really no reason you cannot give them testosterone therapy. I liken it to how I explain that to patients is if they had a twin, you know, who had the exact same prostate cancer treatment and the same PSA, and one of them had a normal testosterone and one of them didn't, you're basically making them equal with their testosterone. So again, there's really no evidence that this is causing prostate cancer or prostate cancer recurrence. Certainly if patients have, you know, more advanced prostate cancer, or, you know, appears they're having a biochemical recurrence after prostate cancer treatment, or obviously anyone who's on, you know, because I do have some patients who are on, you know, Leuprolide or other medications for advanced prostate cancer, metastatic prostate cancer, and they go on the internet and they come in with, you know, stuff. Oh, can I take this medication or that medication? I'm like, well, you could, but that's exactly opposite of what we're trying to do to treat your cancer. So, you know, unfortunately for that patient population, you know, the low T and the symptoms that go with it is kind of just a necessary evil to keep their cancer under control. But you know, I don't have any problem giving patients, you know, certainly after surgery, if their PSA goes undetectable, I go pretty quickly with that. For patients who get radiation, you know, if they sometimes it takes, you know, up to a year for their PSA to kind of bottom out. So I am a little bit more cautious there just to make sure they keep getting down to a good nadir before we start testosterone. But in general, you know, the testosterone is not thought to, you know, increase recurrence risk.
Yeah, that's a great point. I had heard somebody also speaking on testosterone a while back that made the analogy that when we treat prostate cancer, we don't make everybody, you know, hypogonadic. So it makes sense that if you've got, you know, a lot of patients out there have prostate cancer and normal testosterone levels, so all you're trying to do is normalize somebody.
Yep.
That makes sense. So, hey, anybody from our panelists that have a question, feel free to throw that in there. Paula Wagner did bring a point up that their blood bank will not take patients with elevated hematocrit or polycythemia for donations. And I think the therapeutic phlebotomy doesn't utilize that blood. I think it's just wasted, if I remember.
Yeah, I think
right.
it just gets disposed of. Yeah.
So that is.
I was just going to actually mention, because you mentioned sending patients to hematologists, and we, back in the day it was Life Source, but now I think it's Vitalant. We would just send them for monthly blood dumps, what we call them, blood dumps.
Yeah, and that's what that often happens. I like to always get someone more expert than me, that's a blood specialist, to see. But if you don't have it, that option where where your practice is, or easy access to someone, certainly just having them go to to do that at a place like that would be fine. But I like to at least get an opinion of a blood expert before we, just to make sure there's no other underlying cause or anything else going on we need to be worried about.
Thank you very much for this presentation. I thought it was excellent, very informative. I just wanted to point out to our attendees that this would be a great presentation to study up on if you're interested in getting certified.
Yeah, good point. And I'm trying to see if I can get Kathy Marchese to talk, who was a past president of our certifying board, to explain a little bit more about what's involved in certification. I do have a couple questions coming in here. Shilipa Denak, sorry, I'm mispronouncing this, Denakar. We have a few Asian patients who are shy or fearful regarding the use of testosterone. These patients are symptomatic weight gain, have low testosterone levels. What is the best way to educate and convince them regarding testosterone use?
That's a good question. I mean, and just in general, I think this is probably an underdiagnosed problem. So, even if I'm seeing patients for other issues, whether it's urinary issues or whatever, and part of a new consultation, I always ask about their sexual function, their sexual performance, their desire, all that kind of energy levels, things of that nature. Because I think a lot of men are hesitant, not just any specific population, but a lot of men are just hesitant to discuss these things. Or they say, hey, it's just part of, getting older, but, it doesn't have to be necessarily. We do have options, as we just discussed. I mean, I think as far as specific patient populations, certainly there can be some cultural, stigmas or things of that nature for using any kind of supplementation for whether it's, mental health or sexual performance or any of those things. But I think, just explaining the potential benefits, especially if they're gaining weight, if they're, if their lipid profiles are off. Again, the data right now is not conclusive enough to state in the guidelines that this helps all those situations. But, certainly intuitively, if you have, more lean body mass and sorry, I'm getting a lot of feedback all of a sudden.
It's when John's mic went on. Let's see if that. I'm gonna mute you just to see if that does it.
There we go. Yeah, I mean, lean body mass, less adipose, all that stuff. I think that certainly has a lot of other benefits. But if Dr. Lin has something, he has some thoughts, so please.
Oh, I was going to, hopefully this is not interfering with the audio. I was going to mention, when a patient brings, well, first of all, when a patient has a litany of complaints, I try to address one at a time instead of treating multiple things at the same time. And I don't know about you, Aaron, but sometimes addressing the lower urinary tract symptoms improves a man's erectile function. I don't know why, but it seems to do that for some of my patients. In addition, when a guy comes in complaining of fatigue and things like that, to typical hypogonadal complaints, I don't jump straight into testosterone replacement therapy. I start talking to him about sleep hygiene, about alcohol use, about his sleep patterns. Also try to think about obesity. Do they have sleep apnea? And try to address those things first before I put the patient on this potentially lifelong therapy, because I've seen plenty of men, as you have, who comes in with atrophic testes, and now they're, because of chronic testosterone use, and now they're dependent on it lifelong. So before I start a patient on testosterone replacement therapy, I always tell them this is something that could happen. And also infertility. A lot of people don't realize if you are just on testosterone, infertility can result.
Yeah, I think those are
great points.
Some good points there. I had a question for We're still getting that. For some reason, whenever your mic's live, it seems to give us a feedback. Aaron, I had a question for you. So there's so many choices, and it's kind of like with everything in medicine nowadays, it's hard to, tell a patient what your recommendation is when there's so many choices, to give them like all those choices. Do you have like your own favorite? What's your first line of therapy? What you would, then progress to?
Yeah, I mean, I think we typically would start with the topical products. I do offer patients injections, but I think, a lot of patients are somewhat fearful of needles, as I am. So, I think that's, especially doing it themselves at home, sometimes is a little more challenging than just doing some, rubbing some gel on. And as far as, insurance coverage, that is the one product that we can typically get covered reasonably easily. If we document their symptoms, we document at least 2 morning testosterone levels that are below normal, at least a week apart, that we can normally get covered, relatively inexpensively for patients. And a lot of patients do just fine with the gel. I mean, there's nothing wrong with it. It works well. I mean, we used it for a long time, but there certainly are those that, whether it's a risk of transference or, a lot of times, men in general just don't remember to do stuff on a regular basis, or don't like doing stuff on a regular basis and just forget. Or it's just, they just don't want to deal with it. Then, certainly the depot products are really nice. I mean, I personally like the Zyosted option a lot. It's just, again, difficult to get covered. And then for those patients that just want to be kind of out of sight, out of mind, the pellets are great. It is a little bit of a procedure, so people who've been, doing that for a long time, when they come in, they do have all these tiny little, scars on their backside. It kind of looks like a checkerboard at some point. But it does work very well. And the long acting injection is something that we've, kind of been doing a little bit more of lately, just because we've had some better luck getting that covered from insurance, just because, the injectables typically are not going through their Part D insurance, or, their medical benefits, or their pharmacy benefits. So for cost wise, that either the pellets or the injectable has been a little bit easier. And I'm sure Dr. Lynn, if he's very into coding and all that kind of stuff, it probably has the same experience. But certainly some of the oral medications, the pills, and the once a week auto injector, that does go through their pharmacy benefit, which does take a lot of legwork, from the staff to really get all the prior authorizations and send all the notes. So some of the companies have partnered with specialty pharmacies that will help with some of that process, which is really nice. It takes it off of my staff's plate, because they have plenty of other things to work on. Because we want to, make a good effort to get patients the treatment they would like to be on, but we also can't spend, hours on the phone fighting with insurance just to get patient, a specific, oral pill for testosterone, when there's lots of other options. Like, we just, we have enough staffing issues as it is. I'm sure everyone on the call has struggled with that in their practices. So, we don't have extra time just to be arguing with insurance that we want them to be on this specific testosterone pill or, treatment. So.
Yeah, good point. Deb, a couple of questions or comments here. When do you draw repeat levels in the cycle with IM injections? Would that be any different than any other treatment options?
I don't know if it makes a huge difference. I mean, I normally try to do it kind of midweek. So if they're doing it like on a Saturday, Sunday, try to do it kind of midweek, just to see if their, kind of their mid-cycle levels are therapeutic. I'm not sure if there's any specific guidelines or guidance on that. Maybe Dr. Lynn knows, but I think it's sometimes hard to time that. But normally I try to, at least initially when they're getting started on treatment, try to do it kind of mid-cycle, and I do that with the pellets as well. When they first start the pellets, typically we'll do it sometime roughly 6 weeks into their implant. So it's had time to kind of ramp up, and also it's not hasn't started to drop down yet. So to see if the 6 pellets is actually enough, and then if it's not enough with the pellets, there are some compounding pharmacies that kind of make the generic pellets. Some patients will opt to do extra, because a lot of times insurance will not pay for more than that. But certainly, during the height of COVID, when we had, they had a lot of shortages with the pellet production, we did start using a lot of the compounded pellets, and patients did like, getting some extra sometimes. So that's still an option for our patients if they want to, use more. They certainly can do that if insurance doesn't cover it.
Very good. And then also Deb said, I did not know you can give IM injections sub-Q. I don't think it's the IM being given sub-Q. It's the Zyosted is a sub-Q injection, right?
Zyosted is sub-Q, correct.
Yeah. So
And then, yeah, I mean, most often we do, the weekly injections is IM, but actually in the AUA guidelines, it does mention, potentially doing sub-Q weekly injections. I've never honestly done that myself. We always do it intramuscularly, but I don't know if Dr. Lynn has any experience doing that, but it was in the information about testosterone injections that you can do it sub-Q. I've just never done that. Other than the Zyosted, which is designed to be sub-Q.
Yeah, I read that same article because somebody had brought that up before. So yeah, experience that you've seen with it though.
No, because the testosterone in the Zyosted is testosterone. I think it's an enanthate or an anthenate. It's a little different formulation, whereas the typical ones we get for generic injection IM is cypionate. So I don't know if the cypionate works as well when it's sub-Q, but yeah, typically we would do the testosterone cypionate weekly IM.
All right. Well, this has been a really great discussion. I think that we've learned a lot today. I don't see any other questions coming in, which is good. That means we kind of took the deep dive that we wanted to take into today's subject. I would like to thank all of our panelists for being here today. It's been really great. And then a little bit of housekeeping here. We have next week's production coming up, which is going to be slings, and that's going to be presented by Dr. Jay Kim, who's also another member of our group, and he was kind enough to give us that presentation next week. So I look forward to seeing more about slings. And also, I do want to make a personal plea. So we have this thing called the after party that I've had for a while, where we just people who can't get enough of us want to come back, and they would come for a Zoom meeting. So I'm trying to test some new software. So I would like if a few of you can come on to this after party. You do have to go to the UroNurse.com. Don't use the previous link, because it's going to bring you to a new program that I'm testing out called StreamYard. And it's a program that doesn't like Zoom. You have to have the software loaded on your system. This one doesn't require it. It just works through a web browser. But whether it's going to be something better or as good, I'm not sure. So, hey, if I can get a few of you to hit the after party button on the website, that'd be great. Otherwise, I would again like to take a chance to thank everybody who showed up, all of our great panelists every week who make this show possible. And we have a lot of attendees out there. I'm not even going to read all the names, but you know who you are. Thanks for coming for the live show. And for those of you watching us on demand, keep watching. And with that, I'm going to say goodbye to everyone and have a great day. And we'll catch you hopefully in that after party.